get shit done kind of people, and he kind of does things in his systems that many of us are envious of. And today's topic is one of those things where they're providing medication-assisted treatment from EMS, right? And they have just a really robust MIH program. And one of his fellows, Joseph Martin, is the one who's going to be talking about some data that they've collected on that. So let's see if we can bring in David or Joe to the call. David, Joe, can you unmute yourselves and see if you're there? Still not hearing you guys. Let me see. I'm texting you, David. Can't hear you.
Sure, that's not an old age problem with you.
Ah, okay. There you go.
There.
All right, I had to jump out of a meeting. I'm sorry.
There you go.
I can share my slides just a second, and I'll just do it.
Okay, thank you. We got the man himself.
Yeah. So let me share. How do I share screen on this? Or do you have to?
No, right next to the mic button, there's an up arrow. It says share. Click on that, and then click on window.
Okay,
there you go. Perfect. Yeah. Click on play. You should be fine.
Okay, good.
Beautiful.
Here we go. So I'll do a quick overview of the opioid program we have at San Antonio. So, of course, it takes a team. Here's my team. I have no financial conflicts. So what we have is a very different approach to MIH. These are all the service lines. I got more than that actually now. And two of our service lines is the targeted opioid response, the TTOR, and MAT, M-A-T. Both are state funded. It's federal dollars to state to local grant. And then we negotiated as a RAC to do this throughout the county. So we all know that overdose deaths are going up, especially after the pandemic. A lot of folks came out of treatment, unfortunately, and they're not doing so great. Plus, a lot of our narcotic programs shut down during COVID. We got a lot of folks lost. In our area, we have a really increased overdose because the cartels are damn smart, and they're now mixing fentanyl in with our meth. So most meth users, they use for a couple of days and they crash. Well, now they have to use every single day. They have to buy every single day because otherwise they get dope sick from the fentanyl. They got them hooked on fentanyl, even though they're meth heads. So as we know, the opioids affect the brain, right, with the normal opioid receptor, and then the brain on opioids have an exaggerated response to this dopamine reward center. And so when that's not there, they get what we call dope sick, or, in withdrawals, which is really not life-threatening, but they wish they were dead when they're going through that withdrawal program, right? We know that the sobriety method of detox and keep them abstinent with Narcotics Anonymous is not all that effective. So abstinence at 1 year is pretty low, and the mortality rate's pretty high. But if you keep them on methadone or buprenorphine maintenance, their mortality is low and their abstinence rate is high because we substituted a better drug for the crappy drugs they're using from the street with a consistent dose. And we also allow to get their lives together, both economically, psychosocially, mentally, and they actually get into healthcare treatment as well. So also the buprenorphine, as we know, also is an agonist antagonist. So what it does is it prevents overdose. Because it has a ceiling effect, buprenorphine is extremely safe, and the harm reduction effect of buprenorphine is a big deal. So we have a couple, there's vocabulary. TTOR is our Narcan program, morenarcanplease.com. That's actually our website, for replacement of Narcan. And then we have the mobile integrated healthcare program that we use for our MAT. So we know the opioid response continuum is prevention, treatment, and recovery. We're actually in the treatment side, where we do, it says treatment in the office. We treat at the patient's home using MAT, and we do a lot of prevention and harm reduction with the Narcan program, referring these people into peer counselors and into our drug treatment centers. So surprisingly, the biggest thing for success in recovery is not the treatment part, but actually it's the support, the wraparound services, and housing, actually. So you can't focus on your addiction if you don't have a safe place to live, you're not getting food, and you don't have access to healthcare. So it really is an all-inclusive wraparound process that you have to do to get them in a safe place so that they can actually address their addiction. So what I'm going to skip through that. What do we do? So our contracts all stipulate for all of our MIH contracts that if we're going to do a program, you got to pay for it. And we actually insist that all of our units have everything that's on a regular ambulance. So initially our funder said, oh, you just need a blood pressure cuff and a computer and you'll be fine. And we said, nope, you got to have everything because we're going into harm's way. And if the patient gets sick or their family is sick or we walk in and there's a bunch of overdose folks, we need everything we need to do. So our contracts, we actually stipulate that you buy all the normal equipment that's on an ambulance. And then we use these crappy little Ford vehicles because they're cheap. More NarcanPlease.com. So TTOR, the goal is to prevent overdose and to treat the continuum of opioid services. It's more of a triage process. So what we do is we identify everyone who's in the CAD from the previous couple days that have had an opioid related call, and we go out and try and find them. We prevent disease through overdose, decrease the 911 resources for repeat calls, and there's a community benefit of getting people in treatment or off narcs, and that lowers the HIV and hepatitis C transmission, crime reduction. Some of our people are stealing, pimping, dealing, prostituting $100 to $200 a day to support their habit. So by decreasing their dependence on the drug, we're lowering crime in the community. And then we give them access to primary health care and cancer screenings because before they never even were in a clinic, right? And then a lot of times we can get these people back to work or school to better their lives because they don't have to worry about their addiction. They can worry about making themselves better. So we have a pretty big team. We have 2 staffers in the office that do scheduling and all that stuff. And when we target these, it's all overtime. So we offer overtime both to the fire and EMS division. They're trained. We have 2 TDOR medics a day and 2 MAT medics a day. And most recently, to get more bang for our buck, it's a medic and an EMT. We do use some of our fire EMTs in the program to try to give our paramedics a break because we couldn't get them scheduled. And then we always have 2 people, always. That way we have someone who's taking care of the patient, someone's doing the paperwork and being the radio person or the safety guy. We use an app to find our patients. We use First Watch. So every morning we run the report and we reach out to find the folks that were evaluated in the days before. And we go out and try and find these folks wherever they're at. And we actually, when we do need to link them into resources, we use our Signify community. That's a computer system that links our various providers and also provides transparent benchmarking about how well we're doing. And we use this for data collection and generating reports. We use this throughout our MIH programs in the community, whether it be high volume utilizers, psychiatric intensive care, our core program, which is our mental health program. Whatever we use this to benchmark and connect the patients to the community. Food bank, Project Men for DME, whatever they need. And this is an example of the software we use. This was funded by the South Texas Crisis Collaborative, which is part of our RAC. And that's a whole nother topic, but we have a whole bunch of harm reduction models for mental health, substance abuse, domestic violence, you name it. We have a program that's using this process to get through the day. Our medics try to navigate them into programs. We can get them into peer counseling with our drug addiction agency, Sakata. We give everybody Tony kits, patient, family, friends, fellow shooters. A Tony kit, I'll show you in a minute what it is. And then we teach them how to use treatment for harm reduction. Tony kits we have state funded as the Narcan, nasal. It has contact information, how to get more, instructions, gloves, a bearer device to do CPR, fentanyl test strips, and which is kind of useless nowadays because everything we have has fentanyl in it. And then addiction assistance brochures. So everything you need to take care of an overdose and then get them into recovery if they want to get in recovery. We got some results. We're seeing a bunch of people, which is great. And the outcomes, most of the time we're a lot of unable to contact, and that's because those runs are on a street or a bus shelter or whatever, and we can't track the patient, or their cell phone's off, or they just don't answer the door, which is a very common aspect. So we use a fire department model for TTOR. A lot of times we'll knock on a door, they won't answer. They'll be, we'll see people peeking out the window or through the people or whatever, but we leave a card and then we take off. And about 8 times out of 10, by the time we're down the block, they call us. Hey, I don't want to meet at the house. I'll meet you at the carry out in the corner because I don't want my family to know that we're talking, right? Or we thought you were cops. I can see you're a fireman. We'll be glad to meet you. I'll meet you in 5 minutes. Let me get some clothes on, right? So we do not use a cop model. The firefighters in our area are a trusted member of the community, and they know that we're not going to rat them out. The MAT team we have is similar equipment, only they have a lockbox with buprenorphine in it. And the goal is to relieve the symptoms, to bridge them into our program. And our program, it's grant funded. We navigate them into new seasons, one of our contract outpatient providers, and they get 90 days treatment free of cost while we try and get them on insurance or get them squared around. And that can be renewed up to 180 days, depending on their progress. So our goal is we do a basic physical assessment, vitals, a COW score, which is a clinical opiate withdrawal score. And we're looking for a score around 8, okay? Do they have nausea, vomiting, diarrhea? If so, we treat them. And we have to make sure the last heroin use is less than 24 hours, or greater than 24 hours rather, and that they're in mild to moderate withdrawal, or the heroin in 3 days, or methadone in 3 days. So heroin greater than 24 hours, methadone greater than 3 days. And then our treatment plan is we do things a little differently than other folks. We actually pre-med folks. So we give them a big slug of Zofran, Benadryl for anxiety, and for the cramps, Imodium if they have diarrhea, and a gram of Tylenol. And then after they've taken those pills, then we put the buprenorphine strips in. And we do the pills first. That way they can drink, and then the buprenorphine, because you can't eat or drink for 30 minutes after you use a strip because it has to absorb through the buccal mucosa. If they're less than 24 hours, we do use clonidine. We found this to be pretty effective. So we give them 0.2 milligrams orally. We watch them while we're getting all the paperwork together. And then I didn't say this on a recorded line, but we actually leave a dose. In Texas, we're not supposed to dispense, but on the down low, we leave one on the counter, or we forget to give one to pick it up, and we leave it on the counter for them to use later on that night. And then they navigate the next morning into the treatment center at 5 a.m. Why 5 a.m.? I have no freaking clue, but that's when all the treatment programs want our patients in. And then we provide a taxi voucher for them to do that. So exclusion criteria for it: chronic pain, if they're too stoned to participate. Benzos are a concern, because the additive effects. If they're known pregnancy, we can start them, and then we can navigate them into a maternal fetal. We have connections for that. There is no risk of the Narcan being in the Suboxone, but as a sign of caution, most facilities don't use straight up buprenorphine without the Suboxone in it, or without the Narcan in it, to prevent any fetal issues. We don't do people with severe cirrhosis, dialysis, or failure because they're so hard to dose. And if they're unstable, have any other medical issues, then of course we don't do induction. The COW score, you guys probably know what this is. So our guys use a paper form, and then they log it in the ePCR. The inter rater reliability is pretty good. I usually ask them, okay, give me a cow's 8. Okay, what are their biggest scores? Are they having nausea, vomiting, diarrhea? Because that affects what pre-meds we give them. And then we just go from there. And we look for approval of 3 to 5 points on their cow score with meds. So we know they work in the brain really well, and buprenorphine is really good because the kappa effect actually it helps as an antidepressant. As compared to native opioids, and they actually start feeling better in the first week of treatment. And the nice thing about buprenorphine is that it had agonist-antagonist effect, so I don't have to worry about them overdosing the next 24 to 40 hours because all their receptors are snagged by buprenorphine. We don't do naltrexone, obviously, because you have to be off meds for a very significant amount of time before we inject them. So we just use buprenorphine. And of course, we don't use methadone because the vet said we can't use methadone. And methadone's kind of tricky anyway. So buprenorphine is our safest option for induction. And this is what we use. We use a buprenorphine strips, actually the Suboxone brand. Has Narcan in it to prevent diversion. They're like the Listerine press strips. And we just put them in their buccal surface, and this surprisingly they work very, very well and very, very quickly. We already talked about that. So the nice part about buprenorphine is the ceiling effect. You really can't overdose. So we start at 16 and do 24 to 32 milligrams. This is contrary to the ACEP guidelines where they want to go low and slow. We think that's actually stupid, and we don't do that. We start midpoint and go high. So like when I work in the ER, we're supposed to do 8, wait an hour, give them another 8, wait an hour. It's stupid. So we do what's kind of street medicine, and it seems to work out better. And again, remembering that buprenorphine is an agonist for the kappa receptor, which it works as a functional antidepressant, which really helps a lot with their recovery. So contacts, we're seeing a bunch of people. We don't do a lot of Suboxone because they usually have used recently, but we can at least get them referred into treatment. And then a lot of times we'll see them in the morning, and by afternoon they're calling us back because they're dope sick. We can offer them at least clonidine and other meds to get them through until the next day. The goal is to keep them from not using so we can get them into treatment the next day if we don't use Suboxone. And then cow scores dramatically drop. This is from our some data that we did on a poster just recently, and you can see their cow scores rapidly go down and stay down. You say, well, what are you treating them that long for? Well, if you usually it's one day and they go into treatment, but if we catch them on a Friday evening, we've got to babysit them Saturday and Sunday with doses because the opioid treatment center only does intakes Monday through Friday. So we may treat people for 3 to 5 days, depending on the holiday status. And this, we most of the time when we go back, their cow scores are 3 or 4, and they do very well with repeat dosing. So these are some results. We've had 2 episodes of precipitated withdrawals, and both of them, the patients were idiots and lied to us. And the minute they got sick, we figured it out. And they said, yeah, I just used like 8 hours ago. So, and the treatment for that is actually more drug. So we actually gave them a bolus of 16 on top of the 16. Plus we started a line on them and gave them fluids, IV Zofran and Benadryl. Got them better. None of them had to be transported. We just had to stay on scene for a while. And nobody has overdosed or needed Narcan during MAT treatment that we know of. So pretty safe, very effective. And even if they go into precipitated withdrawals, you can manage them without having to transport them to the hospital. And that's kind of the quick and dirty overview if you need more questions. So I'm going to be real honest with you. We're not sure that this is legal. So I contacted the DEA a long time ago, and they wouldn't answer my questions, right? They said, well, we don't know. No one's ever done this before. The reason why we can do it in Texas is because we're a delegated practice state. So my paramedics are actually me. So they're treating as a physician. We do not prescribe. We only administer Suboxone, and we never leave a dose of Suboxone. Now we'll leave clonidine because that's not controlled. So we don't prescribe. We don't dispense, we only administer, and that's under a licensed physician. Every Suboxone administration has to be staffed with a physician. So me and CJ are ex-waivered, and then we have a fellow that's ex-waivered who's actually addiction trained. And so between the three of us, we can get that quickly. The reason why we did this is nobody in our area was doing hospital-based or at the time of need induction. So just recently, our university hospital started a Suboxone ER program, but we've been doing this for 2 years before that. So very successful, low risk, a lot of legwork, but thank God we're grant funded for this because I don't think operationally we could have done it otherwise, funding wise. So that's the down and dirty of it. Who's got questions?
Yeah. So amazing presentation again. How you do what you do is just incredible. But I wanted to bring someone on the call here who has been leading a charge for us in the state. He's a mentor of mine, Ken Shepke. So Ken, you want to come in and talk about your experiences and perhaps something from the state that could be done?
Yeah, absolutely. Thanks. Dave, fantastic presentation as always. Appreciate it. We're doing something similar in Palm Beach County. That's how we actually started our addiction stabilization unit. We started as a program like this, and then we morphed into having a centralized ER that we bring people to, warm handoff. If they need to be admitted, they get admitted. We've got an on-site, same location, addiction stabilization, long-term medical home for these folks, treat their hepatitis C, HIV, dental care, MRSA, psychiatric conditions, and of course put them on MAT potentially for life. And they treat alcohol as well for that matter. So there's good treatments for both those two diseases. They've got fantastic stats. So what we're doing at the state level is trying to take that model and the model like Dr. Miramontes just mentioned and propagate it across the state. We're working with DCF, we're working with OPTA, we're working with the governor's office. So if you as a medical director are interested in bringing this to your locality, I put in the chat already Shannon Hughes, who's sitting in the background there over there. She's my project coordinator for this project. Her email and her phone number in there. There may be some grant money to help you get off the ground. So fantastic program. This clearly works. Every program I've looked at that is similar to this sees anywhere from 50 to 75% long-term recovery for opioids compared to roughly 0 for abstinence therapy. And so I applaud you, Dave. As always, you're doing these great things that we like to copy. Appreciate it.
Hey, Ken, can you mention how you know they're off of it? In other words, you're actually measuring levels of two different things.
So what we do that's exactly we have from the EMS side. So we do exactly what Dave does. And the overdose calls, we call them back. We have a group of folks that just call at the call center, and we'll follow up with them, try to get them back into the program. We'll go to their location, give them medications if necessary. I'm also ex-waivered. When they're in the program, we do drug screening, both for illicit drugs and for the medications that they're being prescribed. And we make sure that, they're not on one, but they are on the other, obviously, that they are taking the medications that are prescribed. We have a board certified addiction medicine specialist who's dual board certified in psychiatry who runs that program. Very effective. And it does look like there's a fair amount of money for this disease in terms of grants from the federal and state level. And that's something we're ramping up at the state level to try to propagate this around the state.
Let me springboard off of that. John Kramer asked Dave, grant funded state or federal grants? Can you comment on that?
So it's Fed money that went to the state that got shoved down to that school of nursing at my university is working the magic with. That's how they got the funding for it, because their goal was neonatal abstinence syndrome prevention. So it started with the OB department and the neonatal folks, and they said, well, how can we operationalize this? Nurses can't do that, right? I could say that. I'm a recovering nurse, right? Nurses can't operationalize. And Nurse Nancy in a Prius that says UT Medicine is not going to be welcome in our community, right? But a firefighter is, because they're usually at the shooter den or that apartment complex a couple times a day, right? So they're a recognized member. So they recognized pretty quickly they could not operationalize a field drug treatment program with their resources. And so that's when they turned to the fire department, because we do weird stuff in weird places, right?
And Dave, Chief Tedesco asks, he says, great presentation. How long did it take to get these programs up and running?
So what's different about my world is I have STRAC. Okay. So my regional advisory council, we do all kinds of weird programs, right? So it took us about better part of a year. And most of it was just the legal stuff. So what we do is we use the RAC as the conduit for money, because going through city council and we can't buy a car and we don't have FTEs. We can't do that as a city fire department. So what we did that is through the RAC, and then the RAC backfills. So, I mean, here at STRAC, we bought 3 cars on a credit card like that, on a credit card, right? And then we refund that through the grant money. Now, it would take me a year and a half to get a truck through the capital purchase process in the city. We did it in a couple days, right, with a credit card. So that's the difference. We use our RAC process to solve many problems, whether it be a paramedic at the homeless shelter, whether it be MAT, whether it be the crisis collaborative. So that's how we pulled this off. And remember, I said key things: budget all your equipment you're going to need, budget the vehicle, because you can't pull one of those out of your butt from in a city, right? Budget all the personnel on overtime, because that's what you're gonna have to use. That's how we pulled it off so quick.
Wow. What I loved about this talk is that you gave so many logistical kind of guidance, here that it's going to be very helpful for all of us. I'm so happy to see that Ken was on the call, leading the charge for us at the state. Shannon, thanks for being there as well. So we're going to pop over to Dr. Pepe's lecture, but Dave, give us the final word. Give us some words of advice if you're an EMS chief or medical director just hearing this for the first time.
So don't be afraid. Then my big final word is don't be afraid. Go for it. Figure it out. The logistics are tough. It's more dealing with your city council and the legal people who don't get this. So just be brave, go forward, and don't be afraid to kind of rustle some feathers, because you're gonna. I mean, my own partner guys are saying, why are we doing this? We're supporting the addicts, right? You have to teach them harm reduction. So we actually last year in CE, one of the whole hour-long presentation was on addiction, harm reduction, and why we're doing this.
I think you and Ken were born from the same mother. God bless you guys. All right, Dave, you're the best. Tell Joe he's in punishment for not showing up on the call. Ken, thanks for your comments. Angus, thank you for everything. And we're going to move over to Dr. Pepe. You can stick around, but I know you're at a meeting, so I'll see you soon.
We're at EMS Grand Rounds. Thanks.
Okay. See you. Bye, guys.